Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. In today's video, we will be discussing disorders of iron kinetics and heme metabolism. As previously discussed, anemia can occur due to various reasons such as impaired red blood cell production, shortened RBC lifespan, or loss of cells. Anemias related to iron and heme are classified as impaired production anemias caused by the deficiency of materials required for hemoglobin assembly. Iron deficiency anemia and anemia of chronic inflammation are caused by the unavailability of iron for incorporation into heme. We extensively describe how the body absorbs iron from the diet, carries it through transferrin to cells in need, and incorporates it into functional molecules such as heme-based cytochrome, muscle myoglobin, or hemoglobin in developing RBCs. Iron may be unavailable for incorporation into heme due to insufficient body iron stores or impaired mobilization. The resulting anemia is termed iron deficiency anemia or anemia of chronic inflammation. Sideroblastic anemia occurs when the iron supply is adequate, but an RBC defect or impairment prevents protoporphyrin production or iron incorporation into it. In cases where the porphyrin component of hemoglobin is in short supply, as with several porphyrias, diseases of impaired porphyrin production, an anemia may develop. Accurate diagnosis of these conditions is critical, and tests of body iron status play a crucial role in diagnosis. Iron deficiency anemia. The causes of iron deficiency anemia include insufficient iron intake to meet the body's demands, an increase in iron demand without sufficient intake, impaired absorption of iron, and chronic loss of hemoglobin from the body. Inadequate intake. Iron deficiency anemia can occur when the erythroid precursors gradually lacks iron. The body loses about 1 mg of iron daily, mostly in the mitochondria of shed skin and intestinal epithelium. The body preserves all other iron from senescent cells, including RBCs, and daily intake of 1 mg of iron from the diet balances iron levels and fulfills the body's need for RBC production, as long as there are no other losses. But when the diet consistently lacks sufficient iron, the body's iron reserves decrease, leading to a decline in RBC production due to the inability to generate hemoglobin. Since about 1% of cells naturally die every day, anemia becomes evident when the production rate is inadequate to replace lost cells. Increased need. Insufficient intake of iron can also lead to an iron deficiency when it fails to meet the requirements of a growing erythron. This often occurs during periods of rapid growth, such as infancy, particularly in premature infants, childhood, and adolescence. Additionally, pregnancy and nursing also create similar demands on the mother's body to supply iron for both the developing fetus or nursing infant and her own iron needs. In each of these scenarios, an intake of iron that was previously sufficient becomes inadequate as the need for iron increases. Impaired absorption. When the diet provides sufficient iron, impaired absorption can still lead to iron deficiency in the body over time. Pathologic impairments, such as malabsorption due to celiac disease, as well as inherited mutations of iron regulatory proteins, like mutations of the matriptase 2 protein, can lead to iron deficiency. These mutations cause a persistent production of hepcidin, which inactivates ferroportin in the enterocyte and prevents iron absorption in the intestine. Diseases that reduce stomach acidity also impair iron absorption by decreasing the capacity to reduce dietary ferric iron to the absorbable ferrous form. Although some loss of acidity accompanies normal aging, gastrectomy or bariatric surgeries can impair iron absorption significantly. Certain medications, such as antacids, can inhibit absorption, and others may bind iron in the intestine, preventing its absorption. Chronic blood loss. Iron deficiency can also occur due to chronic blood loss, which leads to the gradual loss of heme iron from the body over a prolonged period of time. In this case, anemia occurs when the loss of iron continually exceeds its intake and storage iron is depleted. Chronic gastrointestinal bleeding from ulcers, gastritis caused by alcohol or aspirin ingestion, tumors, parasitosis, diverticulitis, ulcerative colitis, or hemorrhoids can result in excessive heme iron loss. Women may experience prolonged menorrhagia or conditions such as fibroid tumors or uterine malignancies that lead to heme iron loss. Additionally, heme iron can be excessively lost through the urinary tract due to kidney stones, tumors, or chronic infections. Individuals with chronic intravascular hemolytic processes, such as paroxysmal nocturnal hemoglobinuria, may also develop iron deficiency due to the loss of iron in hemoglobin that is passed into the urine. Pathogenesis. Pathogenesis refers to the development and progression of a disease or condition. In the case of iron deficiency anemia, the disease progresses slowly through different stages that blend into one another but can be distinguished to better understand how the disease progresses. Iron is distributed among 3 compartments in the body. The storage compartment principally ferritin in bone marrow macrophages and liver. The transport compartment as serum transferrin. And the functional compartment of hemoglobin, myoglobin, and cytochromes and make up a large portion of the body's iron distribution. Initially, when the demand for iron exceeds intake, the body can maintain normal iron levels by increasing absorption from the intestine. This state is not easily detectable by routine tests or patient symptoms. However, as the negative iron balance continues, a stage of iron depletion eventually develops. Stage 1. In the first stage of iron deficiency, the body starts to lose its stored iron gradually. While red blood cell development remains normal, there is a decrease in stored iron, which can be detected by low levels of serum ferritin or an iron stain of the bone marrow. However, since red blood cells can survive for up to 120 days, there are usually no symptoms of anemia and individuals appear healthy. This stage is often referred to as latent or subclinical iron deficiency because the iron deficiency is not yet severe enough to cause noticeable symptoms. The prevalence of stage 1 iron deficiency varies by age and gender, with higher rates in young children and females of reproductive age. Stage 2. Stage 2 of iron deficiency occurs when the storage pool of iron is completely depleted. RBC production initially continues normally, using the iron available in the transport compartment. However, the hemoglobin content of reticulocytes begins to decrease, indicating the onset of iron-deficient erythropoiesis. Despite this, the overall hemoglobin measurement may still be normal, since most of the circulating RBCs were produced during the period of adequate iron availability. Symptoms may be nonspecific, and other iron-dependent tissues such as muscles may be affected. Serum iron and ferritin levels decrease, while total iron binding capacity, TIBC, increases. Free erythrocyte protoporphyrin, FEP, accumulates, and transferrin receptors increase on the surface of iron-starved cells in an attempt to capture as much available iron as possible. Testing for iron deficiency in stage 2 is still unlikely to be performed, even though a Prussian blue stain of the bone marrow would show essentially no stored iron, and iron-deficient erythropoiesis would be evident. Additionally, hepcidin would be measurably decreased. Stage 3. Iron deficiency progresses in stages, with stage 3 being frank anemia. At this stage, there is a depletion of storage iron and diminished levels of transport iron, which prevents the normal development of red blood cell precursors. The red blood cells become microcytic and hypochromic as their ability to produce hemoglobin is restricted. Serum ferritin levels are exceedingly low, and the results of other iron studies are abnormal. The patient experiences symptoms of anemia, such as fatigue, weakness, and shortness of breath, especially with exertion. Pallor is evident, and more severe signs may include a sore tongue, inflamed cracks at the corners of the mouth, and spooning of the fingernails. Cravings for non-food items, called pica, may also occur. It is important to note that numerous individuals may be iron deficient while appearing healthy, and even in stage 3, some patients may not seek medical care because the body is able to compensate for slowly developing anemia. Routine screening tests may not become abnormal until late in stage 2 or early in stage 3, so many patients are not diagnosed until relatively late in the progression of iron depletion. Laboratory diagnosis. The tests for iron deficiency can be grouped into 3 general categories: screening, diagnostic, and specialized. Screening for iron deficiency anemia. One way to detect iron deficiency anemia is through a blood test called a complete blood count, CBC, to show anisocytosis, microcytosis, and hypochromia. When the body doesn't have enough iron to make red blood cells, the CBC results show smaller and paler red blood cells with a wider range in size, anisocytosis, and a higher variation in cell distribution width, RDW. A lower hemoglobin level is also a common indicator of iron deficiency anemia. A higher RDW can be an early sign of iron deficiency anemia, especially in people at high risk. As the anemia becomes more severe, the red blood cells become even smaller and paler, with declining levels of mean cell volume, MCV, mean cell hemoglobin, MCH, and mean cell hemoglobin concentration, MCHC. The red blood cell count decreases and the hematocrit drops as well. Polychromasia, the presence of immature red blood cells, may be noticeable in the early stages. However, the presence of poikilocytosis, abnormal shape of red blood cells as target cells and elliptocytes, is not a specific indicator of iron deficiency anemia. A low count of immature red blood cells confirms that the bone marrow is not producing enough new red blood cells. White blood cells usually appear normal in number and appearance. In conclusion, when the CBC results show hypochromic, paler, and microcytic, smaller, anemia with an elevated RDW but no consistent shape changes to the red blood cells, iron deficiency anemia should be suspected. Diagnosis of iron deficiency. Iron studies are the mainstay for diagnosing iron deficiency, including assays for serum iron, total iron binding capacity, TIBC, transferrin saturation, and serum ferritin. Serum iron measures the amount of iron bound to transferrin, while TIBC indirectly measures transferrin and the available binding sites for iron in the plasma. The percentage of transferrin saturated with iron can be calculated from total iron and TIBC. Serum ferritin is an accessible surrogate for stainable bone marrow iron, reflecting the levels of iron stored within cells. Iron studies are used together to assess an individual's iron status. In iron deficiency anemia, also called sideropenia, serum ferritin and serum iron values are decreased. Transferrin levels increase as hepatocytes detect low iron levels, leading to a decline in transferrin saturation that is more significant than expected from the decrease in serum iron level. Automated hematology analyzers can assess the amount of hemoglobin in reticulocytes, which is analogous to mean corpuscular hemoglobin, MCH, but only for reticulocytes. MCH measures the average weight of hemoglobin per cell across the entire population of red blood cells, which can delay the diagnosis of iron deficiency until a significant proportion of cells become iron deficient. However, measuring the hemoglobin content of reticulocytes can detect iron-restricted erythropoiesis within days, enabling early detection of iron deficiency even in stage 2 before anemia is apparent. The hemoglobin content of reticulocytes is a sensitive indicator of iron deficiency. Specialized tests. Specialized tests are available for the diagnosis of iron deficiency, although they are not commonly used. These tests may show abnormalities that are important in distinguishing iron deficiency from other similar conditions. One such test is the measurement of accumulated porphyrin precursors to heme, which can be elevated in iron deficiency. Another test is the measurement of free erythrocyte protoporphyrin and its chelation with zinc to form zinc protoporphyrin, which can be assayed fluorometrically but are not particularly useful for diagnosing iron deficiency. Soluble transferrin receptors can also be measured using immunoassay. These levels increase as the disease progresses, and individual cells try to take in as much iron as possible. A bone marrow assessment is not typically needed for suspected uncomplicated iron deficiency. Instead, a therapeutic trial of iron can provide a less invasive and less expensive diagnostic assessment. However, a bone marrow examination for iron is routinely performed when a bone marrow sample is taken for other reasons. Iron-deficient bone marrow may appear hyperplastic early in the disease, with a decreased myeloid-to-erythroid ratio due to increased erythropoiesis. As the disease progresses, hyperplasia subsides, and the severe deficiency of iron leads to slowed RBC production. The most noticeable changes are seen in polychromatic normoblasts, which show nuclear cytoplasmic asynchrony and irregular cell membranes. Without sufficient hemoglobin, the cytoplasm remains bluish after the nucleus has started to condense. Please don't forget to subscribe to our channel, activate notifications to get our new videos. If you like our content, please press the like button, and share the video with your friends. If you have any questions, leave a comment below. Now we shall discuss another type of disorders related to disorders of iron kinetics and heme metabolism, the anemia of chronic inflammation. Chronic inflammatory conditions such as rheumatoid arthritis, chronic infections like tuberculosis or human immunodeficiency virus infection, and malignancies are often linked to anemia. The anemia associated with chronic systemic disorders was originally called anemia of chronic disease, but chronic blood loss is not a cause of this anemia. ACI is characterized by a deficiency of iron despite abundant iron stores. This is largely due to impaired ferrokinetics, which is the primary cause of ACI. Hepcidin, a hormone produced by hepatocytes to regulate body iron levels, interacts with and degrades the transmembrane protein ferroportin, which exports iron from enterocytes into the plasma. During inflammation, hepcidin production by hepatocytes increases in response to interleukin-6 produced by activated macrophages. This response reduces the amount of iron absorbed into the blood from the intestine and iron released from macrophages and hepatocytes. Although there is enough iron in the body, it is sequestered in the macrophages and hepatocytes and is unavailable to developing RBCs. Lactoferrin, an iron-binding protein in the granules of neutrophils, and ferritin, an acute phase reactant, also contribute to ACI by binding some iron and making it unavailable to developing RBCs. Production of inflammatory cytokines also impairs erythroid progenitor cell proliferation, diminishes their response to erythropoietin, and decreases erythropoietin production by the kidney, which can contribute to ACI. However, the primary cause of ACI is impaired ferrokinetics. Laboratory diagnosis. In the case of anemia of chronic inflammation, the laboratory diagnosis involves analyzing the peripheral blood picture, iron studies, and bone marrow examination. The peripheral blood picture of patients with anemia of chronic inflammation typically shows a mild anemia, with hemoglobin concentration usually ranging from 8 to 10 grams per deciliter and without reticulocytosis. The cells are usually normocytic and normochromic, although microcytosis and hypochromia may develop in about 1/3 of patients, indicating possible coexistent iron deficiency. The inflammatory condition that leads to anemia may also cause leukocytosis, thrombocytosis, or both. Iron studies, such as low serum iron and TIBC values, show the abundant iron stores in the body, leading to low TIBC values, an indirect measure of transferrin. The transferrin saturation may be normal or low, and the serum ferritin level is usually increased beyond what would be expected for the same patient in the absence of the inflammatory condition. Free erythrocyte protoporphyrin may be elevated, indicating the failure to incorporate iron into heme. In cases where a patient has iron deficiency anemia with an inflammatory condition, measuring soluble transferrin receptors in the serum can help distinguish between iron deficiency anemia and anemia of chronic inflammation. Soluble transferrin receptors levels increase during iron deficiency anemia but remain essentially normal during anemia of chronic inflammation. Additional modifications to the use of soluble transferrin receptors have been developed to better distinguish iron deficiency, latent iron deficiency, and ACI. These modifications involve the measurement of the hemoglobin content of reticulocytes, and the soluble transferrin receptors per log ferritin ratio. The soluble transferrin receptors per log ferritin ratio is expected to rise most dramatically in iron deficiency, whereas in anemia of chronic inflammation, both the soluble transferrin receptors and log ferritin levels remain essentially normal, resulting in a normal ratio. In conclusion, laboratory diagnosis plays a critical role in identifying the underlying cause of anemia of chronic inflammation, and various laboratory tests can help differentiate it from other conditions such as iron deficiency anemia. Sideroblastic anemias. Sideroblastic anemias refer to a group of diseases that affect the production of protoporphyrin, leading to anemia. Unlike in iron deficiency anemia, where iron supply is insufficient for hemoglobin production, the bone marrow in sideroblastic anemia is rich in iron. The iron is present in mitochondria surrounding the nucleus of normoblasts, where it waits to be incorporated into heme. Sideroblastic anemias can be hereditary or acquired, with X-linked and autosomal varieties known. Pharmacologic doses of pyridoxine can help improve anemia in some patients by stimulating heme synthesis, as it is a cofactor in the initial step of porphyrin synthesis. Lead poisoning. Lead can interfere with the production of red blood cells, causing a type of anemia called sideroblastic anemia. Lead poisoning is a condition that occurs when a person is exposed to high levels of lead, a heavy metal that is found in various products and environments. This condition can be induced by certain drugs, such as chloramphenicol or isoniazid, and exposure to other toxins, including heavy metals like lead. Lead is a significant public health concern, especially for children and adults who are exposed to leaded compounds at work or in older homes with lead-based paint. Toddlers and crawling infants are at special risk for lead poisoning because they can easily get dust on their hands and place them in their mouths. Lead affects the central nervous system and hematologic system, leading to impaired mental development and anemia. Symptoms of lead poisoning may include abdominal cramping, vomiting, seizures, and peripheral neuropathy. Lead interferes with porphyrin synthesis at several steps, including the conversion of aminolevulinic acid to porphobilinogen by minolevulinic acid dehydratase and the incorporation of iron into protoporphyrin IX by ferrochelatase. The accumulation of aminolevulinic acid and protoporphyrin can be measured in the urine and red blood cells, respectively. Anemia in lead poisoning is often normocytic and normochromic, but chronic exposure can cause a microcytic, hypochromic clinical picture. The reticulocytes count may be elevated in acute poisoning, suggesting a hemolytic component. Basophilic stippling is a classic finding associated with lead toxicity, caused by the aggregation of undegraded ribosomes due to the inhibition of pyrimidine 59 nucleotidase by lead. Although basophilic stippling is not a pathognomonic finding, it should raise suspicion of lead poisoning whenever seen. Treatment of acquired sideroblastic anemias involves removing the drug or toxin that caused the condition. In the case of lead poisoning, salts of ethylenediamine tetrashic acid, EDTA, are often used to chelate the lead and facilitate excretion in the urine. Porphyrias. Porphyrias are a group of diseases that are characterized by impaired production of the porphyrin component of heme. Heme is an essential component of hemoglobin, which is the protein that carries oxygen in red blood cells. The production of heme involves a series of enzymatic reactions, and when there is a deficiency in one of these enzymes, the pathway is blocked and the accumulation of intermediate products occurs. This leads to the impairment of heme synthesis and the accumulation of porphyrins in cells that actively produce heme, such as erythrocytes and hepatocytes. Porphyrias can be either acquired or hereditary. Lead poisoning is an example of an acquired porphyria, where the inhibition of heme synthesis is caused by the toxicity of lead. On the other hand, hereditary porphyrias are caused by genetic mutations that affect the enzymes involved in heme synthesis. There are several types of hereditary porphyrias, with single deficiencies of most enzymes in the synthetic pathway for heme having been identified. The symptoms of porphyrias can vary depending on the type of porphyria and the severity of the deficiency. Some porphyrias can cause photosensitivity, where the skin becomes extremely sensitive to sunlight and can lead to severe burns upon exposure. Accumulation of porphyrins during childhood can lead to fluorescence of developing teeth and bones, and some accumulated compounds can be used diagnostically to measure free erythrocyte protoporphyrin. In addition, fluorescence of erythroblasts in a bone marrow sample can also be used for diagnosis. In summary, porphyrias are a group of diseases that result from impaired production of the porphyrin component of heme. These diseases can be either acquired or hereditary, and the symptoms and severity depend on the type of porphyria and the level of enzyme deficiency. Iron overload. Iron overload refers to a condition where the body accumulates excess amounts of iron in various cells, leading to serious health problems. This may occur as a result of acquired or hereditary conditions that cause the body to acquire iron at a rate that exceeds its loss. The body's first response to excess iron is to store it within cells in the form of ferritin and ultimately hemosiderin. However, if the storage system becomes overwhelmed, parenchymal cells in organs such as the liver, heart, and pancreas may become damaged. Iron overload can be an acquired condition, which may occur in individuals who require repeated transfusions to treat anemias such as sickle cell anemia and beta thalassemia major. The iron present in transfused red blood cells exceeds the 1 mg per day of iron typically added to the body's stores through a healthy diet, leading to transfusion-related hemosiderosis. Hereditary hemochromatosis is another cause of iron overload, resulting from mutations to genes for proteins involved in iron metabolism. The mutations impair feedback regulation of iron, leading to continued absorption of iron even when stores are full. Hereditary hemochromatosis is a general phenotype that can be produced by various genotypes when a gene for an iron regulatory protein is mutated. The most common mutations in HFE involve the substitution of tyrosine for cysteine at position 282 or the substitution of aspartate for histidine at position 63. The normal HFE protein binds beta-2 microglobulin intracellularly, which is necessary for the protein to appear on the cell surface and interact with transferrin receptor 1. Mutations in HFE impair the signal for hepcidin production, ultimately reducing iron absorption. Without hepcidin, ferroportin in the intestinal enterocyte membrane is continually active and absorbing iron, even when the body stores are replete. Laboratory diagnosis. In the case of hemochromatosis, laboratory testing can serve several purposes, including screening for the condition, diagnosing the cause of organ damage, pinpointing the mutation for family genetic counseling, and monitoring treatment. Screening for hemochromatosis can be done by measuring transferrin saturation or serum ferritin levels. Elevations in these values can indicate hereditary hemochromatosis. Individuals with undiagnosed hemochromatosis may come to medical attention because of organ function problems leading to nonspecific physical complaints, or the disease may be discovered incidentally with routine laboratory testing. Abnormal liver function test results, such as elevated alanine transaminase levels, may be among the first laboratory findings that lead a physician to order further testing. If hemochromatosis is suspected, additional laboratory testing is warranted, including serum iron, transferrin saturation, and serum ferritin testing. These tests can help confirm the diagnosis, and genetic testing for known mutations can provide further confirmation for most patients with hereditary hemochromatosis. Monitoring the serum ferritin level can provide an assessment of the degree of iron overload, and monitoring hemoglobin concentration and hematocrit can also be useful for monitoring treatment. Finally, the extent of tissue damage caused by hemochromatosis can be determined through a liver biopsy, which involves assessing the degree of iron staining and scarring in liver specimens. Thank you for completing the video. Remember to ask for ASCP short notes, and don't forget to subscribe. Bye.